Everybody, welcome to this morning's HOSC meeting of the 20th of October. We look like we've got everybody we expected to be in the room apart from Vicky. Okay, so just before we start the meeting, I just need to inform you that this meeting is being live streamed and recorded, and then all remote participants will be muted at the outset and are able to speak at the invitation of myself. Just raise your virtual hand if you would, if you do wish to speak, and then we'll unmute you when we're ready for you, if that's okay. So on the sheet we've got no kind of apologies for absence, but I can see that Councillor Moore is unavailable, is not present this morning. Any other apologies that we're aware of? No? Perfect, okay. Just going to go around the room and ask about disclosable interests, so just let me know if you have anything. No, perfect, okay, moving on. So we have...
It's me, it's fine.
Okay, great. So we've got just two sets of minutes to note as part of the meeting, the 27th of January and the 22nd of May. So unless anybody has any comments about any of those sets of minutes, I will just move that we note those minutes and move on. All those in favour? Thank you, councillors. Okay. We then on our agenda would have public questions and member questions, but we have neither of those this morning. So I will move on to item number 6, which is the health in all policies. And I will take over to Rachel. Thank you, Rachel.
Thank you, Chair. I think Sophie's going to share my slides. So I'm Rachel Robinson, Exec Director for Public Health. I'm going to be presenting this today just thanks to my colleagues who unfortunately can't be here today. Phil Northfield, who helps lead the majority of this work. He supports a lot of this work. And then previously we had a colleague, Sue Lloyd, who worked with us, who supported the delivery of this programme. So I just wanted to give thanks to them. And obviously, particularly with Phil not being, he's on annual leave today, I can obviously take any questions that we're unable to answer today. But just wanted to go through a brief presentation. We've had the paper in advance, but I thought it'd probably helpful just to step through this. Obviously, there will be the training further that I know members will be participating on in a couple of weeks' time. But I just thought this would be helpful to give a bit of background, and then obviously happy to open up to any questions. So just step through. Thank you. So health and all policies. What the first thing I just wanted to say before we went into this, and just in terms of the paper, is that what I've done is take very much a council approach. So this is an approach you can use across other partners, other areas, but what we've done is started to focus on what we as a council could do to, given that we've got a statutory duty around health and wellbeing, what can we do to make sure that we take that approach, we embed health in all that we do. So I've taken this very much from a council perspective. Health in all policies, as it says there, is an approach to public policies across sectors, but we're focusing on the council here, that considers health and wellbeing implications of any decisions that are made. It looks at where we can have synergies. You can look across organisations. It looks at strategies. What you're trying to do is minimise any negative impacts that a policy or a strategy could have on people's health, and maximise, if possible, any positive impacts, with a particular view to reducing health inequalities. So actually, does something that we're going to do here, would it exacerbate health inequalities? Is there something that you can put in place to mitigate that? So there's a particular vulnerable group. Can you adapt that so that we don't disproportionately increase health inequalities? So that's the whole point around looking at this. From a council perspective, how we've done this, and I've added in the words appropriately and proportionately, because I think given our financial emergency, that's something that we'll have to consider as a committee as we go through. So from a council perspective, we do this by collaborating and putting health considerations into our decision making. So that's the way that we would want to do that, by embedding positive health outcomes into our strategies, policies and plans across the organisation. It is in essence a way of working. So it's something that it's a mindset that we as officers, but also as members, that we have. So we embed, how can we, wherever possible, when we're developing something, consider health and wellbeing. That's effectively what we're trying to do. So it's a way of being. We originally approved this approach by Cabinet way back in 2020. February 2020. We all know what happens then. So this has been something that we've certainly had an ambition around, because we feel that it's the right thing to do with our health and wellbeing duty. But in the recent new direction paper, that's been reaffirmed, and I think part of this is thinking, how could we really do that? At the time, it had general, although it was approved by cabinet, it was accepted by that this was the right thing to do as a council, because of the positive benefits that if we consider health and wellbeing in all we do. So that's the kind of background. If I move on to the next slide. So, I mean, anybody who has ever heard me talk will know that this is something that I talk about all the time. It's why is it really important, and why is it really important as a council, and why do we have duties around health and wellbeing as a council? Because 90% of the things that influence our health are actually outside of the healthcare system. So 90% of things that we do, about 40% of those are things like the lifestyle things that we affect. So, you know, whether we drink, whether we smoke, what we eat, whether we exercise, all of those. The rest of those are the wider determinants of health, and they're all things that as a council and with our partners we can influence, and they have a significant impact on our health and wellbeing. So actually, and we saw this when we did our joint strategic needs assessments, can you actually get to an appointment? We know access to services in a rural county is a real challenge. So transport is absolutely critical for people's health and wellbeing. If you can't get to your appointment, if you can't socialise with people, if you can't get to work, that has a dramatic impact on your health and wellbeing. So 90% of everything we do is affected beyond the health system. So if we want to really improve people's health and wellbeing, we have to think that beyond. So actually, the policies and the strategies that we have as an organisation will impact on people's health and wellbeing. So that's why it's critical. And if you've got that mindset where you're considering health and wellbeing and all we do, we can make a difference by just tweaking and having awareness around that. And obviously the financial benefits of health and all overall, if you look at the return on investment around prevention, if you look at the return on investment around things like good quality housing, we know that that has a big impact and benefits on people's health. And that's well evidenced. The issue is actually how you prove that you go from here to here, because there's actually a lot that can happen in between, and it often takes a long time. But certainly it's really important for long-term sustainability to manage demand, to improve people's health outcomes, and it's a preventative approach. With some of these policies, you can get immediate benefits, but many of them will not be seen for a long time. So just kind of think it's important to flag that. For the next slide, please. So when you think about health and all, and you think about, I've just talked about the 90% of things that sit outside of health. Obviously we all know this, within a Shropshire context, there's just some other things we particularly pull out. And I've already mentioned things like how transport, that came up time and time again when we spoke to communities and we did our joint strategic needs assessment, how you can access services where you haven't got direct bus routes, where you haven't got, if people can't drive, for example. So that's really important. We have an ageing population. We know that we've got increasing demands on our social care. And actually, so again, taking a health and all approach when you're doing planning or when you're looking at housing, we really need to have in mind that the policy decisions that we make now across all of those areas can have a positive impact on health and help manage that demand in the future. And then rurality, I mean, I've talked about it from a point of view of transport, but really we've talked about rural proofing, we've talked about the importance of rurality. So actually in a Shropshire context, just thinking about that, how do people access the services? The isolation impact is significant again. So things, if you put a service in a particular area, we have a policy, and we have had policies where because of resources, services end up in one particular area but not available to other people, then actually that limits people's opportunity to access those services and can lead to further isolation if we take decisions around that. And obviously things like employment opportunities, we know that we've got less, and then people will leave the county, etc. and others. And then the other thing that we flagged really is housing and planning. We know that in Shropshire we've got much higher levels of people living in fuel poverty, for example, than other areas. That really has an impact on people's health, obviously, in terms of where your money goes. We know we've got a low wage economy in Shropshire. People are living on very much smaller budgets than in many other areas. Add that to that, you're spending a lot more money on transport, you're spending a lot more money on fueling your house. That has an impact. So again, there is positive benefits that we can make to try and improve housing. And again, then one of the things that we've certainly come on to is how you design neighbourhoods so that people can actually get out and about, how people can get around and be able to walk safely if you haven't got footpaths down the side of the roads, or if you can't get from one housing estate to your local amenities. All of that, there's things that we can do to just think about that and make sure that we design that in, so and we can design health into some of these where possible within resources. So these are just some of the things that I think are a bit more pertinent to Shropshire perhaps than other areas, in terms of when you're thinking about health and all, where we maybe want to focus our attention more. The next slide, please. So just how does health and all policies and approach work in terms of how you approach that? The first thing that you do is, so everything doesn't mean that you have to do a full health impact assessment. Every policy that we have, you don't have to do a full huge impact assessment that understands what it's quite a large process. If anyone's ever seen a health impact assessment, we've done one around transport. It's a big real detailed assessment of health and wellbeing outcomes, the mitigations. You need to gather evidence from a number of sources. So it's quite a large process, but not everything, you don't jump automatically to that. The first thing that you do is just screen and just say, does this have a health impact assessment? Is a full health impact assessment, or even a shorter one, a briefer one, necessary? You might not need to do that for every policy, but what you would want to do in every policy is just think, have people thought, does this impact people's health and well-being or not? Is it to a greater or lesser extent? So there'll be certain things, like we've said, like the local transport plan. Yes, that could have a massive impact on people's health and well-being, and therefore you would want to go through all these steps, but you wouldn't do that necessarily for everything. So once you've done some screening, you consider if there's any impacts, then if you do need to go to a full health impact assessment, you then look at what those potential impacts could be. So you do some more detailed scoping work, you look at other areas, look at evidence base, then you do your assessment and you work out if that has a high, medium or low impact, and you work out various thresholds, and then you set some recommendations as a result of that, which might say, actually, this particular policy will have a negative impact on these people living in this area, and therefore we'd recommend that you add a shuttle bus, or there might be some mitigations that you can put in place within the resources available to minimise that impact, and then you monitor the outcomes. So if we identify something that's significant, and as I said, we've done things like this around health, we've done it around local transport plan. In a previous life, when my previous role, we did health impact assessment. The NHS did it around stroke services. Actually, the hospital were very involved in that, because there was real implications when you relocated some of those services about how people could travel and access those services. And again, what are the mitigations? So that you would do this. We have done it on a large piece of work where you might see a massive benefit, a massive change, or an impact of a policy that's put in that would disproportionately have negative health impacts. You might want to understand that, assess it, put some metrics in there, and give some advice and recommendations. But my suggestion is you don't need to do that on everything, and we'll go through that. But just to say, this is the process you go through. A lot of things you'd want to do is screening. You just want to understand, could there be a benefit? And you can often put some simple steps in at that point by just being aware of that this could have a benefit, and there'll be some simple mitigations. So the next slide, please. So just to let you know, again, this was in the pack, some things that we've done in Shropshire. So one of the first things to do is we've got an equality, social inclusion and health impact assessment tool. We've used that in Shropshire. That was one of the things that we said we could do. We could put that in place, and that when we have a policy or a service that needs to go through change as an organisation, you do an ESHA on it, the equality, social inclusion and health impact assessment. It includes health impact assessment. So in that, people should be considering health impacts. Officers who are doing that and members and portfolio holders who are working with those would do an impact assessment. That gives us a really make sure that all policies that are coming through should have that, where we need to do an impact assessment, should have that consideration in there at a high level. So effectively, you're doing a bit of screening at that level. If you go back to the last slide, you're kind of screening, understanding that, and picking up anything there. So that is really important, and we need to make sure that that's being used. And I guess you need to make sure that people are trained to understand that they're asking the right questions. And as for example, as scrutiny and portfolio holders and members, have we asked the right questions? So that's important. So that's a fundamental catch-all that we've put in place, and is still there, and we can keep that up to date. And that is used. We've done some work across health actually as well around that. The other thing that we did was actually pull together a Shropshire Health Inequalities Plan. This was a way of working across the organisation to really think about inequalities and how different parts of the organisation can influence and reduce inequalities across our organisation. So that was really a health in all approach that we took to say, actually, if you look at all of the work that we do, and we worked with officers across the organisation, what are the things that are going to impact on health inequalities and reduce health inequalities? And that plan is there. We take updates to the Health and Wellbeing Board. It's very comprehensive. The process itself was actually very useful in people understanding how things that they might, actions that they might take in their part of the organisation could impact on health and wellbeing, and what we could do to improve it. So again, some of the things we've talked about already, transport planning, others are within that, but housing, as well as some of the other sort of more public health areas. So that was some of the work that we've already undertaken. There's some examples then, just of where, as I've said already, I've talked to you about, we did do a health impact assessment. It's quite a big bit of work for the local transport plan as was, and I think we're looking at this being refreshed, so that piece of work is going to be really important, and looking at the evidence around transport policies and planning, how you can maximise some health benefits, but how it can also negatively impact if you don't have that in place. So that was a bit of work that we put resources to and did quite a big piece of work at the time. The other thing that we've committed to, and again, something that you might want to consider, is that we will look at a supplementary planning document, which will help look at, it's a health and wellbeing one that sits alongside planning, the planning policies, to help understand how we can maximise healthy lifestyles within planning process. That will be based on best practices from other areas. That's something that we're going to be working through, and again, we'd want input into that to make sure that's right. But that considers things about walkable neighbourhoods, as we've said, that you don't have too many takeaways in a particular area, that you've got really good community infrastructure so people can get around and use green spaces. That's one of the things that we really key, so people can keep active, all of those. So that is a really critical piece of work that we need to do, and we'll need to resource, and we'll bring in kind of external evidence and learning, and again, committee, something that as a committee you would certainly want to be interested in. So just wanted to flag that as well. That's probably been, in fairness, been a bit delayed because of other bits of work. So these are highlights. Obviously, there's a lot more detail on the report. So that's a much longer list of other bits of work that we have undertaken to date. Training previously, but that will need to be updated now, and all members will be taking part in that. Develop the screening tool I've mentioned there. I've talked about the health impact assessment, just putting in more information on the website, so there's a bit of a signpost so people know where to go and get more information. We have developed a module, but I think again there's a question about how we roll that out and when we roll out to officers, just so people know what we're talking about here. So a bit of training, it's for officers and members can access that. It isn't mandatory at the moment, but how would you want to consider that? Could we put it into the induction programme? Again, we've got to consider that within the bigger mandatory areas that we're pushing at the moment. The other area from a kind of health in all and embedding health into the wider terms is that what we call substitutions. So the public health grant does fund areas across the council and across the organisation. It doesn't just fund lifestyle activity or public health activity, it does fund some of the areas across the organisation. So it funds some of the work that supports hubs, because we believe that will help reduce inequalities. If you think about transport and others, so it's an enabler. Also has links into some of the other programmes like health protection and others that council services. So that's another way that we try and make sure that health and wellbeing, and within that we have certain metrics that we monitor to make sure that we're delivering improved outcomes. And then I've talked about the health inequalities plan. So these are just some of the things that are ongoing and work that's there to build on as we relaunch this work. I think finally, look, in the paper we've suggested, but this is obviously for committee, if we really appreciate committee's view on whether what we do here and what more everybody can collectively do. Obviously there's yourselves, and that kind of the role that you will play in terms of making sure that we've embedded this, looking at the forward plan and making sure that we've picked up some of the policies. So I've said ideally we get to a point where every policy and plan people reflect as have an impact on health and wellbeing, but you would not want to look at every single plan in huge amounts of detail. You want to pick the big wins where you could make a bigger impact, I would suggest. So what are those areas we want to focus in, and really make sure that as an organisation we are having a health and wellbeing mindset alongside our other duties and really maximising that. Training for officers obviously is something we need to consider and think about how could we push that, and members, given the current situation, at what time is the right time to do that. We've talked about working with again, we work with the integrated care system to make sure that when if we need to do integrated impact assessments on any of their policies, I've mentioned stroke services, for example, in other areas, that's not for Shropshire, but how do we make sure that we do that? Communications, and obviously making sure that if we're going to do this, is it having an impact? Has it changed mindsets? Are we seeing much more of health embedded into everything that we do? And I think that's probably near the end in terms of, I've got just a couple more slides to just to think about as we go through this. So just things for consideration. So I think the first one is just around the changing workforce across the organisation. How we've got to be mindful of capacity around this. I think it comes back to how do we not layer this onto people, but how do we really start to embed it in what the future role of officers is, in terms of members' roles. So is there a way we can do this to embed it, but not layering it on when we've got capacity? And I just think, just probably stating something obvious here. I think if there's a challenge to policy, we just need to think about the process. So I think it's that forward planning. As things come through, how do we really monitor those in a meaningful way, that we're not creating a whole bureaucratic process, but actually we don't miss anything, and we have the kind of if people are looking at health and all, and they're doing their assessment of health and well-being, that how do we just check that and say, actually, does that feel it's not just a tick box exercise. We've looked at it and thought that's a reasonable assessment people have made, and use that as a training in a supportive way. So there's something to think about there. Just that point about health in all policies and health impact assessments. So just they complement each other, but they are slightly different. So health in all is more of a process, of a mindset. If you have to do a health impact assessment, that's quite a big detailed piece of work, and it's slightly different. They link into each other, but they're not exactly the same. I guess the point at the bottom is then this is an opportunity, because we can miss things if we, things go ahead, policies, if we don't implement this, then there is a bit of a missed opportunity there, isn't there? If we're doing a new corporate plan, what is the opportunity to make sure we embed this really at the start, and that we don't have policies that contradict or we walk into something that's really counterintuitive and we haven't missed anything. So that's, I think, that, and then the final slide, just next steps. I think this is probably for the conversations we're going to have today, and that these come to some of those recommendations. So I'll probably not talk through those. I just thought it was helpful to step through those if I could. Any questions?
Brilliant. Over to you, Bernie.
Thanks very much, Rich. I just thought I'd add as portfolio holder that just as we will be looking at implementing the rurality toolkit across all policies that are developed for Shropshire Council, including the local plan, the health in all policies document will sit alongside that, along with other general policies to be implemented as individual and comprehensive policies are directed, just to make sure that all of the elements are included in those policy developments, and done so at an early stage and not at a late stage. And for the same reason, it's likely that for health items, that HOSC will be engaged at an early stage in order to develop these to assist, and not at a late stage of simply approving or not.
Thank you, Bernie. I think your last point is really, really important in terms of thinking ahead. Yeah, definitely. Colleagues, anybody got any comments? Any thoughts? Chris, would you mind just introducing yourself?
And pressing the microphone button.
Thank you.
So I'm Chris Naylor. I'm Burnell Division. Firstly, to say I think it's a hugely important policy. It's very impressive, and it really ought to be moving forward. And it's obviously a shame there have been delays in the past few years due to events beyond anybody's control. And it's great that we've got a cabinet and senior staff now picking it up. And as I think you said, relaunching it to get things moving again. So, and having had a background in housing myself, I'm of course totally aware of how housing agencies can play their part in so many ways. Physically better housing, using the kind of networks and the relationships for more informal advice. I was involved in a project which was using somebody, perhaps using the wrong word, who was going out giving rent advice to also give health advice to social housing tenants. So I think there's lots of stuff there, and the points you were making, Rachel, about neighbourhoods and the importance of those is something which I, and I'm sure a lot of other councillors, think when they go into a quotes nasty new estate where there isn't the outside space there should be, and there aren't the thoughts about being able to get to the medical practice and so on. So totally support all of that, and very much appreciate the introduction. But as Bernie knows, sitting next to you, I was slightly concerned going through the report last night that I wasn't quite sure what we as Scrutiny could be adding value on. And I guess my background, having been a housing cabinet member and being scrutinised fairly strongly on proposed policies every month or two, I'm used to seeing a kind of recommendation from officers to say, this is our strategy to take this forward, or this is our policy on that. For us as Scrutiny, as lay members representing our public, to be saying, well, that looks lovely, but have you missed so-and-so? Maybe the timing on that isn't quite right. And as I think both of you have said, we're not quite there yet. I mean, I don't want to put words into anybody's mouth in terms of this. And I think, Bernie, I think you both said you're looking for more of a collaborative way forward on that. But I guess that was my concern looking at this. There didn't seem to be a lot in terms of the future proposals and plans. There's about 5 or 6 items there, 2 of them about task and finish and what we might do. Another is the LGA training, which is great. Another is the training module. But I guess I wonder if it needs to come back to another meeting with perhaps a clearer idea of the recommended way forward that we as Scrutiny could be looking to. Now, it's only my opinion. Others in the room may want to leap into setting up a task and finish, in which case, great that could happen, and that may be a useful way forward. Thank you.
Rachel?
Yeah, thank you. I mean, I think you're right. This report was very much a position statement to get everybody up to date in terms of what we'd already done, what the process was. Obviously, the training will give, I think, will spur more thoughts on in terms of what we do. We have suggested a couple of ways. So we've suggested some work that we'll be doing, supplementary planning and planning. Do we want to bring that back then for a further conversation? I think within there, and forgive me, apologies, I think we're suggesting that you will want to have your own ideas about which areas you focus on. We have suggested that we would want to do more around housing, planning, and obviously potentially come back and look at the work we've done around transport. There's some big areas that we could look at. I guess there is a bit around bearing in mind where we are at the moment, that we've got the new corporate plan that will be coming together over the next few months. There feels like there's a big opportunity in that, just to look at that and make sure that we're really using that as an opportunity in bed health and all. I guess I didn't want to be too prescriptive in this. This report absolutely was to set this up as a way of working with some simple first suggestions, which was around the training and a couple of areas that you might want to bring back to a future meeting for more focus, and then just to sort of set it out in terms of how we're working. So my suggestion within here are certainly things around looking more around some of the planning work. I think housing is a good example of some of the transport, but I think we've got to be mindful that maybe the first thing is something around that overall corporate plan that we take, and then just something about how we embed this as training so people it becomes a way of working, mindful that we need to be proportionate around that. Does that help at all?
Come back to it very briefly. Yes, that's very helpful. And I suppose it may be useful for us to be suggesting practical steps. And the 2 immediate things that occur to me were, we've got that one case study, haven't we, about the local transport plan. Wouldn't it be lovely to have 2 or 3 more case studies like that to be able to be showing? And maybe those might come from neighbouring counties. I don't know what the context is there. And the second point is, of course, the governance model we have here is very much one of a strong cabinet taking the lead, looking at resources, working with senior staff and the manifesto to move things forward, and of course while we can be scrutinising, maybe there are opportunities for cabinet members to spend half an hour or an hour very specifically on this, and maybe to report maybe on an annual basis, say, on how the HIAP way of working is being taken forward. Sorry, that was a bit long. Thank you.
I'm going to move to Colin now, if you don't mind, Bernie. Colin.
Thank you. Thank you, Rosie. A couple of observations and a question, but to thank Bernie for being so specific about linking rural policy to this this new programme, if you like, or revisited programme. So thank you very much for that, because I look after one of the most rural patches in the county, and it's a real issue down in the Corvedale in every sense. So thank you for that. And the other is a sort of observation about the breadth of this. It's absolutely huge. I mean, I welcome it because from a health background and commissioning background, to me, it's sort of common sense. So as you say, if we can embed this in training and the way everybody works almost every day, feels very valuable to me. But the breadth of it frightens me in terms of what Chris is making is how do we become focused on things we can actually do in a relatively short space of time, given the resource problems we have. So those are some considerations. There was a final thought which has now gone, so I'll move on from that. So thank you, Chair.
Okay, Bernie.
Thank you, Chair, and thank you, Colin. And I think we should declare that we knew each other from a previous existence. Both we were in our positions within healthcare. But I think it's really important to emphasise that the value of the Health Overview and Scrutiny Committee is not just in looking at and criticising reports. It's actually being there at the formative stages. And I think this is the crucial difference between how Health and Overview and Scrutiny Committees have previously performed, not just here, but other places as well, and that there are often been lost opportunities and time which could have been spent developing the best outcome, and then review it at the end as well. But as I say, I think that's pretty vital, and so I, in particular, and the whole of the cabinet welcome the scrutiny committees to play an active role here. But Rachel also alluded to, or actually specifically said, that we need to be careful that the outcomes are going to be cost effective. That is, that the items that we specifically look at and spend a considerable amount of time and officer effort in are likely to have the best outcomes for that particular topic that's being considered, and not to take a catch-all approach and trying to solve everything. Dawn.
Thank you. Given the financial emergency and the need for faster and more flexible decision making, I'd like to suggest that the committee give authority to the chair to be able to set up task and finish groups as necessary to enable the effective and timely pre-decision scrutiny that Cabinet and the administration are implementing across the board. This has already happened in other scrutiny committees and is helping to speed up decision making, and hopefully is assisting the Cabinet to make better decisions. Thank you.
Okay.
On behalf, I welcome that. Thank you very much indeed, Councillor Housen.
Mandy.
Yeah, thank you. You know, like everybody else here today, you know, it seems very sensible, you know, to include health in all council developments and policies. I suppose my only concern is around cost, and the cost of this, the cost of the training, the cost of officer time, given the emergency, the financial emergency that we are in at the moment. And also it's not very clear, I think, from the report what the return on investment might be. That's kind of a little bit woolly at the moment. So maybe some clearer indication of that would be really, really helpful.
Thanks. So just in terms of the training, it's a really good question. I should have said that. So the training, obviously, for members is fully funded by the LGA. So we've got a real opportunity to use that. It's free, so free of charge to us. So it's important that we get as many people to come to that as possible, because it's a way of making sure that we embed that. The module itself in terms of training is all fully developed, so it's more officer time, and I think it's for us to consider whether that's, at what point do we want to include that, because obviously it is officer time to do some of that and present some of it. So they're not a cost, it's the time. I think I guess through the development of this process and through the work that we're going to be doing, we just need to consider, do we target certain individuals and certain groups? I certainly would like to see it as part of the introductory training, because we have duties around health and wellbeing, so it's quite straightforward. It's being developed. But I think we then need to just consider if there's certain officer groups we'd want to target to make sure that they understand health and all, and particularly those who are helping develop some of those policies. So, but the training is free. It's that time, and I think at the moment, what I'm not suggesting at the moment, but the committee may want to suggest something different, is that it's mandatory because of timing. But I do think we need to think about that going forward in terms of introductory training, and would want to target at certain groups. I think the return on investment, actually, really good point. In previous slides and presentations, we've included quite a lot around that, and I've put some of those into my report. I can share those around this. There'll be quite a lot of work done around return on investment in certain areas at a very high level, in terms of why you invest in some of the housing or the planning or the obviously a green environment. So some of those are there. So I can share. I'm happy to share that with committee. There's quite high return on investment in many of these, but it's the problem is actually the time that it takes to get that through, and how you evidence that you've actually got it out of here from here. Yes, it's very, but I've got some information I can share. Some of the stuff King's Fund have done an awful lot around that as an example.
Chris.
Sorry to come in again, but just I hope constructively to help clarify the point about the task and finish group. And I guess I earlier mentioned the kind of model of having a strategy as Scrutiny, looking at it and commenting on it. You, Dawn, have reminded us that scrutinies have been doing pre-decision scrutiny. And I wondered whether what we're talking about here and what would be useful to our colleagues is something like that, which is looking at a paper before it goes to Cabinet, or whether it's more of an informal, ongoing discussion. And I suppose each of those could be great, but I thought maybe as we don't have these meetings in public very often, it would be useful to try to clarify what our colleagues might feel useful, and indeed what we as members would want to join in. Is that a reasonable question? Thank you.
I'm going to bring Tom in at this point.
Thank you. So I'm Tom Dodds, the Council Strategy and Scrutiny Manager. It's just sort of highlight, so take us all the way back to that first conversation that we had or you had as a committee. And this particular topic was identified as a good gateway for the whole committee into the Council's duty of health and wellbeing. And I think really really what it's doing now, that conversation about what is it, what's the purpose of it. And I think the extension of that was, if you as a committee are more confident in the topics and the focus that you have, then you have the opportunity to identify the areas you want to focus in on. I think Chris's point earlier, right at the beginning of this conversation today, was it might be a bit early to say some of that, and it possibly is, because you haven't had that LGA training session yet, and there's further work to be done. So what I would suggest is the topics and the things which come from this and tie to this might still be to emerge. There may be specific ongoing work that you as a committee want to do around this and its development and its implementation, which ties into what Chris is talking about, the strategy, how is the council taking this forward and implementing this. But equally, as a gateway to understanding more about what's happening, you will move into that space which is both going to be pre-decision, so what's coming up that is going to have a decision made about it that you could look at and ask those challenging questions about how have you considered health and all policy in this development, and doing it at an early enough stage so that those officers and portfolio holders who are involved in doing that work and taking that strategy and policy development forward have a chance to take that on board and take that into account as that goes. But equally, turn that same challenge around. Rather than how you've done it beforehand, it could be, show me the evidence of how you've done it. So it's you as a committee, you're not. I suppose what I'm trying to say is the question is the right question. You don't have to do it one way or another. You can ask it on both sides. So I see this as your gateway into these topics. Some of it will pre-decision and will be task and finish group and done between meetings. Some of it will be more holding to account and what have you done in the committee meetings. I think as you grow more confident with this and more confident with the topics, you will feel more confident in moving between those two different points of direction and focus. So at this stage, I wouldn't want you to feel like you have to go one way or another. It's just bearing that in mind.
Bernie.
Thank you, Chair. So I'd just like to echo what Thomas said, but add that we're not just talking about pre-cabinet scrutiny. We're talking about much earlier in the process as well. So I need to emphasise, I think, that the most efficient use of the resources is at the formative stage, and so there may be some preliminary topics that need to be progressed to the point of a report, but to involve the scrutiny committee at an early stage means that ultimately it's likely that less resources are going to be involved, because we're not going to miss things out, that the committee will find things at an early stage that efficient time can be spent on. And so the other point that I'd make is that while some of the topics are appearing, like the local plan, the corporate plan, others are not yet appearing. So things like the planning strategy, which is still very early in its stage at the present time. But when there are draft proposals that come through, that is likely to be the time at which the health overview and scrutiny committee and the portfolios are going to impact on that.
Yeah, I think I can use the example of the partnership plan work that's been undertaken, where we were calling the witnesses, we were gathering the evidence so that we could, at a very early stage in the process, advise the cabinet on pitfalls, problems, things that they need to be aware of at a very, very early stage to hopefully set it up in the best possible way. But towards the end of the verbal report that was just given, it then said, right, and then we're going to need to, in 6 months' time, go back and do the post-decision scrutiny, see how well has that been done, how can we improve it going forward. So I'm seeing that's sort of the both ends of that spectrum happening here. Thank you.
Rachel.
Thank you. I was just going to kind of give an example of how I think that's really helpful in terms of the conversation. Complete support what's been said, and in terms of taking both approaches. I think in terms of the task page, for example, we're very early on in terms of starting to develop the corporate plan. Looking at Tom because we're involved in that. The corporate plan and the improvement plan. Everybody will be involved in that, and that will have to move at real pace, obviously, and particularly the improvement plan bit. There will be. Previously, we've done equality impact assessments on the kind of corporate plan and the medium-term financial strategy, because we know there's going to, and this more than ever, that we know there's going to be difficult decisions and areas in there that we might not be able to mitigate that would have impact. So from a scrutiny lens, are we actually thinking about that? Are we all thinking of what the health and wellbeing implications could be, and if there is anything we can do to mitigate those? I'm not saying that there always is, but going into that, being very aware, being able to have those conversations with both the public but also with other partners is really important. So there's something in that quite early on, how it's developmental. It's you could do that earlier on. Then practically, the example I would give of what you might then want to do, actually call in, is so previously what we did, I mentioned the substitutions. One of those, for example, was into health protection. We asked people to come and tell us, how are you using this way of working, not just the resource that you directly receive, but also the broader resource to impact and improve health and wellbeing outcomes, and have that conversation. Actually, this was some time ago now, but a positive conversation around, actually, are you doing that? What more could you do to influence and improve health and wellbeing outcomes in the work that you're responsible for? You could take that approach in other teams, which you think, and services that will have the biggest impact, like we've said, housing and others. So I think there's potentially, but we have to be mindful of officers' time at the moment. And I do suggest that probably the biggest impact at the moment is likely to be as we develop that plan. And then obviously in terms of the work of the supplementary planning guidance and others that we could influence. But that's probably just my suggestion. The other bit is just making sure people are aware of this approach, because that in itself will have a significant impact. If you've got that mindset, as you do things naturally, you start to consider how you could actually, I've got a duty around health and wellbeing here. I think it's just even knowing that we have responsibilities around that. Certainly from my experience when we did the inequalities plan, started to change the way that people just approach things naturally. And I can't quantify that. I can't tell you in terms of measuring an outcome how much of an impact that made, but we just know that it has changed how we think as an organisation, how we work and how we consider some of this. So that in itself will have a positive impact, no doubt.
Colin.
I'll try this better this time. Colin Stanford. So to come to the idea of how we might tackle a particular problem with some health issues attached to it, if you like, a policy. One of my worries is that we can use the scoping exercise that Rachel talked about, but I'm nervous that there may be a certain threshold at which we're pitched into a health impact assessment, and that I imagine would be timely, or rather time consuming and cost consuming. So I just want a little bit of guidance, and perhaps this is difficult to do without we know what we're talking about, but that is a concern because these sort of safeguards are built into the process, and it would be nice to know where the cutoff is or the thresholds are for that. And then coming back to the point about cost effectiveness that Bernie made, it's notoriously difficult, as Bernie will know, to demonstrate positive health outcomes for the population in almost any area. I've tried to do it and got frustrated by doing it in the past. So in terms of cost effectiveness, you may be looking at activity, let's say, in terms of, I don't know, cycling to work or walking to school. To demonstrate the health benefits in a population is much, much harder. So you need to be mindful of that. And when you're looking for value for money, it has to be countered with some assumptions, I think, about what is healthier for people based on other evidence rather than what we can produce here. So that's really what I wanted to say. Thank you.
You got any further comments about policy at this point in time? Okay, Bernie.
Thank you, Chair. Just one final thing, and that is it's clear that if we can materially affect the well-being of those who are most deprived and most in need within our community, and we do have some tools that have allowed us to do that, such as the joint strategic needs assessments that have identified specific areas of particular deprivation, then it may be possible to show benefit in those areas, and in particular a reduction in the numbers of years spent in ill health in those groups, which, as we know, is substantially greater than those who are more affluent.
So Dawn proposed earlier that the concept of setting up task and finish groups was delegated to myself, and I'm suggesting to Dawn as well, in partnership. Are the committee comfortable with the concept of having that mechanism that allows us to set up some task and finish groups in between meetings, given the breadth of our meetings? Is there general agreement about that concept? Yeah, okay, that's useful. And then I guess that the last question is, based upon the fact that we've got the LGA training coming up, which previously was due to be before this meeting, but is now afterwards, is there any areas that we want to specifically kind of tag now as things that we want to look at, or do we want to wait until the LGA training afterwards? You've got recommendations in the report. We've made discussions already around, housing and planning, etc. I'm sure the LGA training may not change those priorities anyway, but Chris.
Thank you, Chair. Just quickly, as I mentioned earlier, are there interesting points which the LGA might be able to help us learn from other counties or other experiences nearby? Because there's, of course, a tendency here to be looking at what Shropshire does, and it's great, I think, if they could help us learn a bit from other areas.
Yeah, and those other areas might give us better indications of health outcomes versus interventions.
Exactly. There may be other counties which are a bit further down the road on this, or indeed maybe less far down the road, and we can learn from them. Thank you.
Yeah. Okay. Mandy.
Yeah, it's only just a really quick point about the training. It's great that this free training is going to be provided, but I know, for example, I won't be able to attend that due to work commitments. I'm sure that I won't be the only member that has other commitments and can't attend. So anything you can do to provide it in another format or record it in some other way would be really helpful.
Just going to bring Sophie in.
Hello, I'm Sophie Foster, Overview and Scrutiny Officer. Yes, absolutely. We've already been in discussions in terms of what else can be provided following on from the session, but I have been able to commit that I'll be able to attend the session and take action notes. So in terms of case studies, themes, things that would be of support and help for the committee will be shared.
That should help. Yes.
Sorry, and I should say members more widely as well, because it is an all-member briefing, so it's open to all members. Sorry, just to clarify. Thank you.
Okay. So, unless councillors, members have got anything further to add in terms of specific topics at this point in time, Lynn, is there anything you wanted to? Perfect. Okay. Okay then, councillors, we then will move on to item number 10 then. And we have the update from Joint Hosk.
Thank you, Chair. Yeah, so Sophie Foster, Overview and Scrutiny Officer. So I'll just begin by giving a really quick sort of high-level overview of the activities of the Joint Hosk, and then I'll hand over to the members of the committee who are part of the Joint Hosk if you wish to add any further detail or developments there. So over the last quarter, the Joint Health Overview and Scrutiny Committee has continued its role in identifying and looking at developments in terms of the services in terms of the system level. So this is any changes or developments in the health service that impact the wider health systems, that's both Shropshire and Telford and Wrekin. The committee's work has focused on the following areas. So in terms of being involved in informal briefings and receiving information, the members heard in terms of about the group model proposal. So they were briefed on the plans for Shrewsbury and Telford NHS Trust and Shropshire Community Health NHS Trust to form a group model with shared leadership. GP out of hours briefing. The committee participated in a wider briefing from the Health Hero and Integrated Care Board on the GP out of hours service contract, engaging with service representatives and discussing implications for local provision and service changes more widely. They considered updates on a briefing on the prescription ordering service with a focus from the committee in terms of rural access, digital exclusion and public transport challenges. The committee has had one formal session since the last meeting of this committee, which was held on the 6th of October at Telford. And the agenda there was to review the Shropshire, Telford and Wrekin system winter preparedness, where updates on system readiness for winter, including operational pressures, vaccination plans and communication strategies were shared and scrutinised. And the hospital transformation update, where a progress report on the HDP with where there was discussion in terms of next steps and implications for local services, again with a real focus on rurality and digital access and transport. Thank you, Chair.
Thank you. Is there anything you want to add at this point in time, Dawn?
No, a particular bugbear of mine is the potential for digital exclusion for a lot of our residents, and every opportunity that I have when talking to anyone in the NHS or on these committees, I try and reiterate just how bad that situation is in a number of our areas. And that is sometimes that is infrastructure. I have literally complete dead zones. Badger, a village of on my district, there is no mobile signal there at all. And I'm trying to get people to understand that, yes, we're as a society becoming more digitally literate, but that changes over time. My mother was particularly good on a computer up until she was about 82, 83. And now, and her health needs are increasing, but her capabilities online are decreasing. And it really is important to me that that is built into every decision that we're making, that these people are helped and included as things change for them over time. Thank you.
Yeah, I think we've really focused as a joint HOSC on that digitalisation aspect in terms of the outcomes from the 10-year plan, in terms of Health Hero and their selling in terms of kind of access to support people virtually rather than in person, in terms of hospital transformation programme, in terms of communities and all those different aspects. And you know, our local NHS is really passionate about the ability to be able to use virtual wards and other ways of accessing patients that aren't necessarily face to face. However, we still need to bang that drum, don't we, of there's a cultural aspect and there's an ability aspect and a geographical aspect to digital exclusion. So that's definitely been, that's definitely been a thing. I think we spent quite a lot of time in terms of that hospital transformation programme briefing and that discussion at Telford last, around some of the proposed changes which will have an impact upon our residents in Shropshire, and going back to those pre-decisions and that pre-scrutiny aspect that Bernie and Chris brought up, having that opportunity to really remind people of rurality concepts in terms of where your A&E is going to be or where your urgent care is going to be, and some of those implications of moving services around. So that felt positive in terms of having that pre-decision and that impact, because it's a 3+ year programme of changing our hospitals in Shropshire, Telford and Wrekin. So that's our impact, isn't it? And that's really important. So I think that's,
I wasn't sure if Lynn had a hand raised.
brilliant, Lynn. Absolutely, Lynn, that would be lovely, thank you. And if you just introduce yourself, that would be marvellous.
Hi everyone, I'm Lynn Cawley and I'm Chief Officer of Healthwatch Shropshire, and I am a co-optee on the joint HOSC, and I just wanted to completely agree with what your comments about digital exclusion, and it's something that Healthwatch, not just Healthwatch Shropshire, but as a network, we're really focused on. We were the first health, I suppose, part of our system who did a report during the pandemic, actually, where a lot of the work that's now being cited as part of the 10-year plan was triggered, particularly that move to being online, and the impact that had. So if you need any evidence and experiences of people who are struggling to access online, that might be a good place to start. And we followed it up a few years later with another report about that, because it's not just people who are able-bodied, it's people with disabilities and hearing loss and everything that were impacted, and sight loss as well. So we've done a couple of reports, and every meeting that I go to across the integrated care system, I am saying the same thing. And I'm also saying the same thing about older people who may have that ability. And yes, we can train people if they want to be trained, but at some point we will, unfortunately, all lose the ability to use technology. And then what do we do? The other thing to report on is that for 2 years nearly, I've been trying to do a piece of work around virtual wards to understand people's experiences of using them. I did have a meeting last week with the clinical director about this piece of work, and they are very in support of us doing it. But the challenge that we have, which is the challenge we have in a lot of the work we do, is that we need them to help us to reach out to the people who've used the virtual ward. We don't want to hear from people who just have an opinion. We want to hear from those people, and that's the challenge that we always have, is to reach them. And so we've developed a survey together. The idea is that one of their members of staff or a volunteer will phone people who've used the virtual ward over the last few months or even 2 years, and get their lived experience of doing that, because I think there is a lot of people who are really benefiting from that, and I think there's a massive misunderstanding amongst the population on what it is and what it isn't. So I'm hoping that maybe in the next quarter or two, I will be getting some feedback about virtual wards.
Okay, that would be really useful then, thank you. And I think going back to Chris's point about having case studies as well around transport plans and things, it might be worth linking up to Healthwatch in terms of anybody that has experienced transport challenges in terms of accessing health.
That would be really helpful, because we cover the whole of health and social care. We want to hear about every part of the system, everything that people are finding difficult, but also everything that's working well. And transport very much comes under our access point. So we do hot topics as a way of trying to get more information about a particular theme, but they tend to be focused on issues that are coming through in order for us to get even more information. So, for example, at the moment, our hot topic is on access to medication. Transport may well play a part of that. You know, because I know that not all pharmacies do deliveries and things like that. Some pharmacies charge for it and some of them don't. So if there's anyone who's got an experience about access to medication, be it physical access or it not being available, if you would ask your constituents to contact Healthwatch Shropshire, that would be amazing. Thank you.
Thank you, Lynn. I think my personal experience from listening to residents in Ellesmere is their challenges that they can't travel between Ellesmere and Whitchurch, and yet those two towns share a GP practice, for example, but it takes them rather longer than it should do to get to Whitchurch if they ever needed to. Bernie.
Thank you, Chair. I just wanted to add that there are a large number of sources of information, and indeed a local councillor advised me of some issues at a particular pharmacy, which I was able to then pass on to Healthwatch Shropshire as well as to the internal part of the organisation, so that remedial action could be taken, and of course further information on what the underlying problems were. So I just like to highlight there are lots of different ways of transmitting communication to this organisation, but also to Healthwatch, and of course to the organisations where the problems lie as well, which is also important. They need to know.
Okay, thank you. Adam. Of course, just introduce yourself, that would be great.
My name is Adam Pfeiffer. I'm councillor in Monkmoor, Shrewsbury, and Lynn. Well, we work a few times already, and I'm just only wonder, in your professional opinion, because we know that the Healthwatch and Shropshire in general is very rich in volunteering sector, and I'm just only wonder, in your opinion, your voice as a representative of VCS sector is heard, and let's say value for the either council, ICB or ICS in health issue especially.
I think Healthwatch has an advantage in the sense that we're a statutory organisation and a charity. So that means that we're in meetings that the wider voluntary sector can't join, and I do try to represent that view, but I think in general the voluntary sector isn't well represented in the integrated care system, and it's partly due to their capacity. You know, they're trying to do the work on the ground, and it's about having the people available to make a point and argue a case. So in my professional opinion, there could be better representation of the voluntary and community sector, and I know that the sector feels under a huge amount of pressure at the moment. Like us, many organisations are struggling to find volunteers, and when a lot of our services are moving into the voluntary sector, that could be a challenge going forward.
Okay, thank you. Very quickly, Benny.
Yes, just very quickly, I'd just like to remind members and anybody in the audience who's listening that the Voluntary Services Assembly has got its annual general meeting next month, and there are open invitations. And so if you go onto the VCSA website, then you will be able to access their AGM and participate. Thank you.
Thank you for that, Bernie. I did see that on an email coming through. Thank you. Okay, we will therefore move on to item number 11 and over to Rachel.
Thank you. So I'm just going to give a bit of an overview of what happened at the last Health and Wellbeing Board, but obviously Councillor Bentic as co-chair will want to come in and add some more detail. So you'll have seen the agenda. The Health and Wellbeing Board, as you know, is split into 3 parts actually in terms of how it works. The first part tends to be a lot more items on discussion. We tend to theme those items, and the theme this time was very much around kind of winter and frailty and vulnerable people. So that was the strong theme. Then we have items for information, then items for by exception, where we have a briefer discussion, and then those items that are information important that we have them, but we don't go into the detail. In terms of the items for discussion, we discussed the winter preparedness plan that also went to joint HOSC. We did that in 3 parts. We talked about the STW winter plan and looked at what activities were happening. We had a presentation from Gareth Wright, who talked about what have been submitted and the feedback and the plans that have been put in place, but obviously joint HOSC also looked at that. We also then talked about the vaccination plan, which is a part of the winter plan. And whilst the vaccination plan is looking at all vaccinations and improving uptake across all vaccinations, including children and young people right up to adults, for winter, obviously we need to get ahead in the winter and make sure that people are getting vaccinated, particularly the flu, the COVID, the RSV. And so talked about that, but there is, we're encouraging everybody. We've got a members toolkit, it's on the members gateway now, to just push that message out to communities. The more people that get vaccinated who are in the relevant categories, the better really. Particularly, we're already seeing things like COVID starting to circulate, and we'll expect to sort of see as the season goes on, unfortunately, flu and others. And then we talked about winter wellbeing, because actually coming back to health and all, actually, if you think about it's not just about what health services are put in place and that we were able to respond in the winter. We know we'll see surges. We're already seeing some of those. Then the preventative work around the vaccinations, what is the activity we can all take. But we also talked about, as we'd already talked about, things like housing, homes, income, all impact on what people can do in winter, and have an impact on whether people might end up in hospital or they're more vulnerable. So we have got a really good offer. We did a lot of work when we went into the cost of living crisis, again partnership wide, to look at how we can mitigate the impacts of the cost of living crisis on our population. We work very closely with the voluntary sector to pull together, and we've got a poverty and hardship group who looked at what actions we needed to take to support our communities within the resources that we've got. Again, we've got some really vulnerable communities in Shropshire. Because of the low wage economy, it means that people are disproportionately impacted, particularly in rural areas. And I know I keep saying the same thing, we all know it, but there's some really good offers there. So we've got a cost of living page, it's been updated, it's got loads of information about food, where people can get support, some of the services that have come through the Household Support Fund. So we had a really good conversation and discussion around that, and we're able to signpost people. So again, actively trying to promote those offers that are available and the work that's been done. And then we talked about the frailty strategy and the frailty strategy that's been produced, the activities that need to happen around that, and actually then again, how do you link the two so make sure that the right people are getting the right support. We had a brief conversation about the Better Care Fund as well, again, particularly some of those aspects that are more around prevention. And then in the information section, we always have an ICB update. We had our pharmacy needs assessment, which we have to publish statutorily as a Health and Wellbeing Board. It's a strange one actually, because it's obviously the commissioners are NHS England who commission the pharmacy services, but we provide that update. Certainly shown that some of those something we don't have access to as many services as that we'd want, so that goes back to the commissioners. And then the final bit was around my annual report, which this year we have now finished all the GSNA work. I know there's difficulties about whether the place plan areas are the right places, but what we did do is committed to go and not just look at a Shropshire level, but actually going into our communities as far as possible and understanding what the health and wellbeing needs of those communities were. Didn't just look at data, we engaged with populations and stakeholders. That piece of work is now finished, and there's action plans in each of those 18 areas that's been co-developed with partners that are not just for Shropshire Council, they're for partners to really understand what the issues are in our areas by locality, obviously laying up some of the other areas. So I kind of commend that report to you in terms of being able to look at as a benchmark at some of the issues within communities around health and wellbeing. And then we've kind of got an overview of some of the some of the overall health and wellbeing outcomes that we need to be addressing as a community. So they were the kind of sort of key issues, but I think the first section was really how we tried to bring together that vulnerable population and not just think from a health service, but actually right the way through to what we can do as a council, what we do as communities to support them, and there's a lot of information there to push out. But sorry, I'll probably hand over to Councillor Benting.
Thank you, Benny.
Thank you very much, Rachel, and thank you, Chair. And I'd first of all like to acknowledge the fantastic annual report that Rachel Robertson has produced, and commend that to members and the public. It's well worth having a look at, and thank you very much for that. And it helps to build a case for what we should be doing on a whole population basis as well as individual groups. And so there were 5 main areas that we went into, and I won't mention the health equality impact strategy and toolkit because we've already gone through that this morning. But with regard to the winter plan, this included NHS England and local ICB assurance processes. And the NHS assurance visit was on the 4th of December, and the test exercise was undertaken locally in the ICB on the 17th of September. So it would be good to have a report of the results of those assurance tests for this organisation, for this committee, as well as for the people of Shropshire. Gareth Wright also indicated the NHS and ICB reset. As you know, there are a lot of changes taking place, would be quite disruptive and may affect their ability to command and control. And so we need to be careful of that. There have been a number of urgent and emergency care programmes of work, including additional capacity schemes and opening of the two new rehabilitation and recovery wards, which will be on the 1st of December 2025. And I think that's about 56 beds. It was originally a different number. And so that should hopefully improve the physical capacity of the Royal Shrewsbury and Princess Royal hospitals. And additionally, some workers will go off site, so there may be more parking. Then moving on to the vaccination improvement plan. In the last year, of those eligible for flu, it was over 70%, for COVID 25%, and respiratory syncytial virus 29% of those eligible that actually received their vaccinations. But of particular interest is that in healthcare organisations, it was only 45% for flu, and COVID was 11%. And of course, these are areas where there is high transmission, and so there's encouragement of those organisations to try to improve their vaccination rates. And overall, the government target is to increase vaccinations in all areas by 5% this winter, compared with 24-25. And there are a number of main subgroups. The age-related ones, 65 plus, but of course 75 plus for things like RSV and pneumococcus. Those in care homes, young children, those people at risk with chronic illness, frontline staff, contacts of the immunosuppressed, themselves, primary and secondary schools, and the deprived and ethnically diverse. And we've identified 9 particular areas in Shropshire that are of increased need, and we are planning to roll out additional support. So I think we should also just mention, Rachel, that the MMR and HPV vaccine rates are not where they could be, and that when the winter vaccination programs are waning, that perhaps we can put a bit more effort in there. With regard to the cost of living issues, there is a helpful web page at Shropshire Council that communities and social media should be aware of, so signpost people to. And these are not only just details of what's available from Shropshire Council, but voluntary sector organisations, the Household Support Fund, details of food banks and community meals, warm spaces, and lots of other resources as well, and lots of signposting. So it would be great if these had a lot of publicity and priority. Moving on to the healthy ageing and frailty strategies. And so a definition is quite important, and it's defined as a gradual reduction in physical resilience, leaving people vulnerable to sudden changes in health triggered by otherwise small events, such as a minor infection, changing medication and environment, and increases the risk of 6 major issues, that is falls, disability, admissions to hospital, long-term care, isolation, and cognitive decline. And those with high levels of deprivation and need are most at risk. So the numbers who are over 65 will be rising from 125 to about 170,000 by 2040. Which is including an increase of 50% in the over 80s and doubling of the over 90s. And these people in these categories have got very high needs, and it's estimated that without intervention, costs will more than double from just under 300 million to 700 million per year, just on the outcome of frailty. And so there are 5 strategic principles: education, prevention, identification of those most at risk, management, and care. And that is care when it's unplanned need. So hospital admission or other unplanned events. And so the system objectives were of improving the lives of people in older age and to help extend people's lives in good health, maintaining independence and well-being. With regard to the Better Care Fund, those of you who may not be aware, this is a pooled budget of both the Integrated Care Board and the local authority, that is Shropshire and Telford and Wrekin councils, and has a total of £50 million for this financial year. And these are aimed to deliver the integration of health, housing and social care. And so it's very important that these budgets are maintained. And of course, with financial pressures on both the Integrated Care Board and the Shropshire Council, it's important that there's a lot of dialogue about whether these budgets are able to be fully exercised. They are supposed to be statutory. Provide contacts for those of the Better Care Fund programme at the NHS, and I can make those available to the chair. I won't go into any great detail about Rachel's excellent report for 24-25, but just to say that circulatory disease is the main contributor to life expectancy between the least and most deprived people, with tobacco being the highest risk for both cases, followed by BMI, high cholesterol and high blood pressure. And there was also the need for access to dentists, community healthcare, GP services, and issues related to hospital and emergency services. So I won't go into that in any detail because that's all in the report, but just to give you a flavour of some of the important areas that need targeting. And to just maybe go to the recommendations, which were on place-based neighbourhood and community working, the alignment of all partners with regard to improvements in healthcare, and including joint strategic needs assessment intelligence, and continuing to work together as one community of partners. The one small thing I'll say about the pharmacy needs assessment is that this was presented previously in June, but when it was when an update including the consultation was presented, it was clear that there were adequate services if neighbouring authority pharmacies were included. And that is that the number of pharmacies at the periphery of Shropshire was small, but that neighbouring authorities often had pharmacies just over the border, which would be available to those Shropshire residents, but particularly that there was poor out-of-hours provision, including night provision and weekend opening hours. And the Health and Wellbeing Board made a recommendation to the presenter to look at a strategy for improving out-of-hours services. Thank you.
Thank you for that, Bernie. You're absolutely right about pharmacy. A lot of northwest Shropshire access pharmacies and doctor surgeries over in Church into Wales. So, and I would like to echo your thanks about the report. It was really useful to be able to pick out geographical health data about Ellesmere, for example, and share that with my town council. Something that they were not necessarily aware of in advance, and it's a really useful concept. Looking at kind of mortality rates across gender and age, and also kind of specific areas. So Ellesmere came up with women's health as a priority area, which is really important for the town council to consider in their future planning. So thank you.
Thank you, Jack. Can I just ask? I did send the report summaries to members. I just would like some feedback about whether that was useful and whether we should continue to do that, because busy members that attend other areas of activity of the council may not always be able to be cognizant of what's being discussed in the health arena. And I did get some individual feedback from one or two people.
Personally, I would be very grateful. So thank you, Bernie.
Thank you.
Okay. Unless there are any further comments in relation to item number 10 or even 11, we'll move on to item 12, which is the work programme. At this point, I'm going to bring Sophie in.
Thank you, Chair. So I've just popped the draft work programme up on the board. It's the one that was published along with the papers, so hopefully you've all had a chance to have a look through already. The only addition that would be in there was, it's on the back of today's conversation, which seems like perfect timing, is that Lynn's very kindly agreed to provide an all-member briefing in terms of Health Watch Shropshire and its role as well, so that again is sort of what the discussions have been in terms of having that lens to just be able to recall to mind when looking at certain topics that actually that partnership with Health Watch could add some real value, and sort of understanding how that might happen. So that's something that isn't currently covered on here, but which will be organised soon. So in terms of the work programme, this is absolutely owned by you as a committee. This is yours. I just administrate it for you, but it's your decision in terms of what goes on here and in what priority order the topics are reviewed and investigated. It's very likely that each meeting it will have changed, because as you have already discussed today, as you learn more from other briefings, as topics change and emerge, that you'll come to them thinking actually things need to move around and be prioritised. And as I say, I won't go through them, but you have got some fixed dates in there in terms of the health in all policies, which is fixed for the 6th of November. And again, likely from discussions already had today, that will be a key factor in then what this work programme looks like going forward, especially in terms of your next meeting, which will be in January. So deciding on what you'd want to then return for the public meeting then as a topic and what you want to scrutinise. It's deliberately quite focused, so it's not a huge list in terms of the declaration of the financial emergency, this has really influenced the committee's working, and as Dawn and Rosie has referred to already, in terms of the needs to be able to work at pace for the committees to add value. So it's likely that this will be very iterative and changing, as required. So in terms of next steps for you as a committee, I think it would be just to pose some questions for you to reflect upon and then to discuss. So are there any topics from either today's discussions or some of the briefings that you've had that have given you more information that you feel are missing from this list in terms of being a priority area? Which areas do you feel, if you can decide at the moment, given discussions, it may not be able to decide at the moment, which areas you'd like to prioritise in terms of focusing on to add value, and whether you require any further briefings or investigative work to be able to make some more of these decisions. And then, eventually, it may not be possible for today to make that decision on which topic you'd like to be able to bring then to your scheduled meeting on the 26th of January. Okay, thank you, Chair.
Thank you. Chris, you look like you're ready to talk.
Thank you, Chair. All I was going to say, and sorry, I've been distracted by something, an email which has come through. What are we doing about scheduling, looking at the out of hours, the new service? Is that on that list somewhere? Because I think when we'd sat down and discussed that, one of us suggested that once it had got rolling, that it might be timely to have a look at how that was working.
So
sorry if I've missed something.
No, that's been dealt with by Joint HOSC, just because it covers both Telford, Wrekin and Shropshire. So our concept and our thought process around that was that we would get a briefing, acknowledge it and understand it, and then review it 6 months down the line in terms of what are people's experiences of it, how have they felt about it, how have they experienced it over a winter period. So with the concept that we would revisit it again for April time, and some evidence from Lynn and other areas would feed into that review.
Thanks for reminding me, and sorry to have missed the plot slightly. But finally on that, would that then be coming to a formal Joint HOSC public meeting? Yeah. Would that be our intention, which is I'm sure what our residents, our public would
Absolutely.
like?
Yeah, is that formal review with NHS partners to say this was rolled out, ICB, this was rolled out, and this is our experiences that we've received from the last 6 months. What are you doing? Are you aware? Those challenges, those scrutiny challenges.
Thanks very much.
No problem. Lynn.
On that note, just to say that if you do hear any experiences, good or the not so good, about the out of hours, we'd be really interested. We've previously done 2 reports about out of hours services, and so we're very keen to follow that up. We haven't identified it as a hot topic where we put a big push out on those comments, but if we start hearing things, then we can do that to try and give you some more information when you come back to visit it in April.
Thank you. Dawn.
Can I suggest that immediately following this meeting, we prioritise getting the task and finish group set up and running, given the amazing time constraints that we are under, and the difficulty in just getting diaries together and getting officer time and relevant witnesses in front of us. I feel that we really do need to sort of get it started, because we're not that far away from November already. And then Christmas and everything is going to massively impact that as well. Thank you.
Terry. Of course you can, Terry.
Oh, it has gone on. So something that I'm quite concerned about, is very relevant at the moment to Baston Hill, is the health policy, the health and all policy related to planning, because there are and there will be lots of planning applications that are sort of going to come into an awful lot of communities. And quite a few of them don't seem to be putting an awful lot of effort into open green spaces, connectivity. how soon are these SPDs going to get through? Are planning officers going to be made aware? You know, can we start to use those within comments that we make? Does anyone know any of this at the moment?
Bring Dawn in then.
There was quite a discussion about planning, and that is actually one of the topics that we would like to get first on the agenda, so that it is really important. So that would be the first thing I think that we'd actually be looking at, to make sure that we've got that information to feed out.
Rachel.
Yeah, I mean, the guidance has been drafted at the moment, but it'll obviously have to go through a process, and it depends on officer time and looking at kind of best practice. I'm hoping that towards the end of the early next year it should be ready. I know that's not great in terms of time scales, but yeah. Yeah, and there's lots of information out there already that we can feed in any issue, but what this will do is give a guidance. Well, it goes alongside that, so that they can use that. We can refer specifically to that supplementary planning guidance that people can then use. But so we are working on it and trying to work on it as quickly as we can.
Yeah. I think as a kind of annotation to this agenda item, we put the local implications of the NHS 10-year plan further down the line, just because we still don't know as much about it. It's not something we are ready to talk about yet until we get a bit more information about what it looks like and how it looks like. But we've definitely prioritised kind of neighbourhoods, community and family hubs, in the sense that that really sets us up in terms of preventative health and some of the things we really want to look into a little bit more. And I think that for me, that definitely needs to be a task and finish group area, something that we can, as a committee, spend some time examining. Wendy.
Thank you. Wendy Owen from Oswestry North. As well as everything that we're already prioritising, I think dentistry is something that's not specifically mentioned on there, just the access to NHS dentists everywhere. So if that could be.
That's really interesting, because that's the conversation that Rachel and I had earlier, having had toothache over the weekend. Bring Rachel in then.
Do you want me to just answer? I think the Health and Wellbeing Board have looked at that a few times in the past and kind of keep it on their radar. I'm happy to bring some of that forward, but we did have a conversation about whether it should be more of a system-wide piece, because it's obviously affects health and access to dentistry is a sort of broader issue, and it's one of these ones that are commissioned more broadly. But yes, I think we did have that conversation. It's definitely something Health and Wellbeing Board have been interested in and keep under review. But even at Health and Wellbeing Board, we felt that it was something that probably should be looked at as across the system. There has been some work undertaken around health impact assessments, actually, health inequality, and additional services put into areas which have got lower uptake and access. But it would be great for the committee to see and understand some of that. And also there's a bigger bit around prevention in dental care, which I think is really important. So
just going to bring in Lynn first, if that's all right, Bernie.
I know I keep saying this, but we have done a report about access to dentistry, and I remember going on the radio to talk about dentistry. And what a lot of people didn't understand was that as businesses, dentists are not obliged to offer any NHS dentistry. But I do know that in our system there has been work to try and increase the availability, but particularly for the very, very vulnerable and young people and children. So I know that there is work happening, but there will never be enough NHS dentistry for that population.
Thank you, Lynn. Bernie.
Thank you, Chair. Just to say that this is one of the high priorities that we have, and that perhaps the committee might have some dental professional representatives come to talk to the committee about the dental provision in Shropshire and Telford and Wrekin, and what things are happening, how things are developing, what the current blocks to universal provision are, and to obtain not only an understanding but perhaps a commitment to better provision, particularly, as Lynn has said, for children and young people who have got an enormous amount to gain from good dental services.
Yeah, agree. Thank you, Wendy. Colin.
Thank you, Chair. Having read through the executive summary of the new NHS 10-year plan and drawing a deep sigh of breath having done so, I felt it was very aspirational. May not be so much reality in there, but it does hang a lot on AI and technology and digital. And I know it's on Sophie's list on the board there earlier. And I wonder whether digital inclusion and ways of mitigating those who can't include should almost sit across everything that we do, because rather than hone in on it specifically, which we should do, it almost sits across everything. Because it's not so much digital inclusion, it's digital exclusion, as Dawn points out. How do we reach those people who won't have access to the ideas and the technology and the communications that we want to get out there? You know, this would be true for neighbourhood hubs as well. You know, because some people can't reach them, but can they do it digitally? Probably not. So just to flag that up, really.
Yeah, I think you're absolutely right, Colin. And it might be that we start looking at kind of neighbourhoods, and we end up doing a piece of work on digitalisation as well. And yeah, there's so many things that we want to do immediately. But yeah, and that's what I said in terms of my reflection on the joint host things, is that digitalisation does impact every aspect that we're looking at the moment. So we do need to keep considering it. Lynn.
Hi, you're going to wish I hadn't sat at the table.
Not at all. Not at all, Lynn.
No, I was just going to say that because I go to so many meetings, I think it's important to see digital from two sides, really, because we have got a system that is one of the least connected as well in the country. So, you know, as a county, we can only benefit from money coming in to improve our digital. That's the only way we're going to get one care record. It's the only way that we're going to get professionals talking to one another in a timely way. So I think it's important to see it in two sides. You know, we do need that technology. We do need that equipment in the hospitals. We do need that support for the poor workforce. But we also need to remember the people who might be the users at the other end who might not be able to do it. But for me, digital advancement, we have to recognise that it is the only way that our NHS will survive. But it's also about how we support the population to deal with that cultural shift and understand that that sort of care doesn't necessarily mean that they're going to get poorer care, but we are the sort of conscience of this system about the individuals who are scared at the concept of it becoming a digitally enabled NHS.
Yeah. I couldn't agree more. I think the steps moving forward in terms of the NHS being accessed by family and friends for a person to represent them, but there's still a lot more to do. So yeah. So members, we've got those items there as a work programme. Is there anything else at this stage that you want to add to this work programme? And like Sophie's already said, it will chop and change depending upon what we learn and what changes and what happens and what comes out more in terms of 10-year plan, etc., etc. But unless there is anything else, Sophie?
Just from some listening to the discussions both earlier and with this item, just whether the committee felt it would be sort of valuable for me to schedule in an informal meeting, sort of maybe a couple of days after the Health and All Policies LGA session. So those members who aren't able to attend, I'll commit to getting those notes turned around really quickly so that you're able to access the information and then to be able to sort of look at it again with the sort of the benefit of that information too in terms of the work programme and where the committee would want to move to next, if that's helpful.
That would probably have an advantage in terms of setting up task and finish groups as well, wouldn't it? So yeah, training relatively quickly, notes, and then informal meeting probably online, so we can really hone in on what our thoughts are, and I'm sure housing will come up as an example amongst other things, so and planning obviously. So okay. If colleagues have got nothing further to add about it at this stage, we're all waiting in anticipation of our training. the last item is the date of next meeting. We've talked about it already, Monday the 26th of January. Add it to your diaries if you may. Very much appreciate your presence. So unless there's anything further to add, that's the close of the meeting. Thank you very much, everyone.